a recorded message, so we'll get that to you guys. Just a bit of housekeeping. We have the Cincinnati meetup September 21st, and then we have the Dr. Noonan 5K coming up here. So look on our website and on Facebook about that. And then again, we've got registration going for the conference. So that's all exciting stuff. So we have kind of two presentations. One's a real quick one by Michelle Gray, who is a genetic counselor master's student at Houston, Texas, and she is studying Noonan syndrome for her thesis. So welcome, Michelle. And then after Michelle, we are so lucky to hear from Dr. Browning, who is going to talk to us about the oral manifestations of Noonan syndrome. And I have loved his presentation since the first one I saw at conference. Amazing information, none of which is really out there in the public about Noonan syndrome. So we're just grateful to have him as one of our medical advisory board members, and then be able to hear him now and then again at conference. So thanks again for that. So Michelle, I'll turn the time over to you.
Great, thank you, Tammy. And can you guys see my screen? Or Tammy, can you see it?
Yes, we can.
Okay, perfect, thank you. Well, thank you guys so much for having me. I'll just be doing a brief introduction. So like Tammy said, my name is Michelle Gray, and I'm excited to share a little bit about my genetic counseling master's thesis project with you all. So my research is focused on healthcare transition in the Noonan syndrome community specifically. And so during this brief presentation, I'll give you a short overview on what healthcare transition means, why it matters, and then a little bit about my project and how you can participate if you're interested. And so starting with what is healthcare transition? So healthcare transition is the planned process of moving an individual from pediatric care, which is where someone primarily sees doctors who treat children, and moving them to adult care. And so it's recommended that the transition planning process start around age 12, but most transitions occur later, usually between the ages of 18 and 21. And the goal of healthcare transition is to make sure that individuals get age-appropriate medical care as they grow up. And then also the goal is to avoid any interruptions in care. And so I believe this image on the bottom really reflects the experiences of a lot of families where transitioning to adult care can be especially difficult if a child has a genetic condition or has any chronic medical needs that need continuous care. And when I was looking in what research has already been done on healthcare transition, I saw that there are some previous studies out there that have explored the transition process in other genetic conditions, some of which I've listed here, including Turner syndrome and also neurofibromatosis type 1 or NF1, which may sound familiar because it is another type of RASopathy, just like Noonan syndrome. But whenever I was looking in the current research, I saw that there were not any studies that have been completed on healthcare transition in Noonan syndrome specifically, even though it is one of the most common genetic conditions. And so the fact that there isn't any research really highlights a current gap in what's been explored in the past and the need for research on the transition process in Noonan syndrome, which is the motivation for my study. And so I'm not doing this study alone. I'm very fortunate to have some really amazing individuals on my committee, a few of which are likely familiar faces. So I'm collaborating with Pilar Magulis and Dr. Rini Pierpont, who are both members of the Noonan Syndrome Foundation Medical Advisory Board, as well as the fabulous Tammy Bowers, who, as you know, is the president of the foundation. And so together, we really want to make sure this project is meaningful and helpful for you and your families. And so my last slide here, if you are interested in participating in this study, it is an online survey. And so we're inviting two groups of people. The first group are parents, caregivers, or guardians of children with Noonan syndrome. And the children would need to be between the ages of 12 and 17. And then the second group that we're looking to participate are adults with Noonan syndrome between the ages of 18 and 30. And because a lot of the conclusions we'll be making in this study are about the US healthcare system and how it prepares individuals for transition, we are limiting the study to those who live in the United States so that we're able to look at the healthcare system specifically. So if you are interested, you can complete the online survey. I put the QR code here, and there's also the link right below the QR code if you want to type it into your browser. I do want to emphasize that the survey is completely anonymous, so we don't ask for your name or contact information. It just asks about your transition experience, but we don't collect any personal information from you. And the survey does take about 10 minutes to complete. And so your input will really help us understand your healthcare transition experience in areas where additional support is needed. And the goal of this study is I'm currently writing a manuscript that we would ideally, once the project is completed, submit for publishing. And so the goal is really to increase awareness of Noonan syndrome and increase the amount of research and literature that's being published on the condition. So thank you guys so much for listening. I'd love to answer any questions anyone has. If you have questions that come up later, my email is down there at the bottom as well. And then I'll also be staying on to listen to the webinar. So feel free, you can message me directly or message me in the chat if you have any questions. And I'll put the link for the survey in the chat as well. But thank you guys. I'm happy to answer any questions before I turn it over. Thank you.
Thanks, Michelle. And then, yeah, if people don't have her email address, you can always reach out to me and I can direct you to Michelle. Super excited about the work you're doing. So thanks for involving us. And let's go ahead and turn the time over to Dr. Browning. So time is yours now.
All right. Thank you, Tammy. All right, let's go ahead and get started. Yeah, I'm Dr. Browning. I've been in private practice for 18 years. I am a periodontist. So I specialize in gum surgery and dental implant surgery. And like Tammy said, I'm the dentist who is on the medical advisory board for the foundation. Been involved with the foundation for about 8 years, and I've given the dental lecture at each Noonan syndrome conference for about the last 10 years. Speaking of conferences, our next one is in Austin, Texas in 2026. It's at a wonderful resort. If you've never been to Austin, it's a great place. Tammy and Lindsay and the crew have worked their butts off to make this what I think will be the best conference to date. And speaking of Austin, Texas, that is me and that's my son Ethan at a Texas Longhorns football game last year.
Hey,
And
Dr. Brownings.
hey.
Sorry, you'll have to just go click that share button again just to put your PowerPoint back up on there.
Okay. Teams. Let's see. So I'm in chat right now. Teams. I'm clicking the teams.
Yeah, it was just in that screen before where it's got like the camera and the mic and the share button.
Yeah,
up
I'm
in
not
the top
there.
right.
Meet. Nope.
Sorry, because Michelle shared her screen and was showing a couple slides, so then that booted
Yeah,
yours
all right.
off. And
Let me get out of Teams
There we go.
and come back in. Hang on.
I'm out of the big one, honey. Okay.
Share. Presenter mode. Here we go. What about that?
Yep,
We see it now.
You got me?
I see the picture at UT. So
All
if you
right,
want
let's
just
go to
into
presenter
presentation
mode.
mode, and you should be good.
All right, so again, that's me. That's what we just talked about. That's me and my son Ethan at the Texas Longhorns football game last year. My interest in Noonan syndrome is based on the fact that my son Ethan was diagnosed with Noonan syndrome at 9 months of age. So we're fortunate that we live in Lexington, Kentucky. And if you don't know, that's the home of Dr. Noonan. So we're really blessed to be in the same town that she was in before she passed. Now, this next slide, I want you all to pay attention to. Take a picture of it. You're more than welcome to email me at any time you want. That's my personal cell phone number. If you have any questions, any concerns, if maybe your dentist doesn't know anything about Noonan syndrome, certainly happy to help. I have a little cheat sheet that I made up that you can take to your dentist, because a lot of dentists, not only do they not know the symptoms of Noonan syndrome, they don't even know what Noonan syndrome is. So if you'd like that, just email me, let me know. So now let's talk about the dental problems in Noonan syndrome. Most issues occur during the childhood and the adolescent years. And the good news is by the time those with Noonan syndrome reach adulthood, these dental problems will normalize so that those with Noonan syndrome have no difference in dental health than the general population. Now we're going to structure this lecture into 5 different divisions. The first one will be structural and developmental issues of the jaws, structural and developmental issues of the teeth. Unfortunately, we do have to talk about one jaw tumor of significance. We'll talk about the eruption of the baby teeth and the permanent teeth, and we'll talk about when the baby teeth are lost. And then we'll talk about what we call malocclusions, and that's just where the teeth don't fit together as they should. There will be 2 things I will not cover, so please don't ask because I will not give you a satisfactory answer. Will not cover any sensory issues or oral aversion issues. Those are best handled by an occupational therapist or a speech pathologist. The Noonan Syndrome Foundation has a wonderful occupational therapist named Lisa Otto, who speaks at all the meetings. And she is wonderful at educating you and handling issues such as this. So the number one most common finding in Noonan syndrome is crowded teeth. Now, the reason we have crowded teeth differs whether they are in the upper jaw or whether they're in the lower jaw. So why do we tend to have crowded teeth in the upper jaw? That's something that we call a high palate or a narrow palate. That is the second most common dental issue in those with Noonan syndrome. So tooth crowding is first and the high palate is second. So what is the palate? Well, it's the roof of the mouth, the hard bone. You push your tongue up to the roof of your mouth. That's what it is. That's the palate. The anatomy of it looks like this. Pay no attention to any of those words. I just want you to pay attention to that vertical line that goes right down the middle of the palate. We're going to come back to that and we'll figure out why that is so significant. So when teeth form in the arch should be U-shaped, like you see the famous St. Louis arch here. And if you look at this picture on the left, that is a normal U-shaped arch. And there's plenty of room for the teeth to erupt. They're not crowded. But if you look at the picture on the right, the arch is V-shaped. And when the arch is V-shaped, the teeth just don't have enough room to erupt. So what happens? They overlap each other and they get crowded. Picture on the left is a normal palate. Below that is a normal bite. Pictures on the right, that's what a high palate or a narrow palate looks like. And if you look below that, you'll see that the bite is not quite ideal. Another, excuse me, another picture of a high palate. You can see how those two front teeth just don't have enough room to erupt, and they are crossed on top of each other. Fortunately, the high palate is a very easy fix by an orthodontist. It's an easy fix, and it's a very quick fix by using a device called a palatal expander. And this is a device that's anchored to the molars of the teeth, and it has a screw in the middle, and it has a keyhole. You see the little hole there, and that keyhole it's essentially a jack screw that you put a key in, and you turn it once a day. You turn it once every other day, and it will expand the palate in as little as 1 month. So you can see the high palate on the left side. A couple months later, after using the palatal expander, that's what it'll look like after the treatment is done. The next one is a pretty drastic case that happened in only a period of time of a month. So that's the high palate on the left, and then after the palatal expander on the right. So you can see how much the palate is expanded if you look at those two front teeth, how much space has been created. So why can this happen so fast? So if you remember, I told you to look at the anatomy of the hard palate. There's a line that goes right down the middle. So the hard palate is actually two bones that fuse in the middle. Those bones are not fused until the age of 12. So basically, that line is just cartilage. So because they are not fused, and because that line is basically just cartilage, the palate will move apart very, very quickly. So that's the dental implications of the high palate. Unfortunately, the high palate has issues outside of dentistry. So if you think about it, the palate is the roof of the mouth, but it's also the floor of the nose. So we're looking at a cross section of the nasal cavity. The higher the palate, unfortunately, decreases the size of the nasal cavity, decreases the amount of air that passes through the nose. The smaller that the nasal areas are, the more difficult it is to clear the mucus. This leads to congestion, and it can lead to an increase in sleep disordered breathing. That's one of the two reasons. We'll discuss the other reason here in a second. It also caused another problem. So the division between the right nostril and the left nostril is called a septum. When the septum develops, it likes to develop in a vertical fashion. Well, if that palate is high, the septum doesn't have enough room to develop. It will still develop, but it will not develop in a vertical fashion because it just does not have enough room. So it will collapse on itself and it will deviate to one side. So what this does, it will decrease airflow through one of the two nostrils. So we can see the high palate causes tooth crowding, causes breathing issues, and it will cause our breathing habits to actually change. So obviously, if you can't breathe through your nose, you've got to breathe some way. So it turns a lot of people into what we call mouth breathers. Humans did not evolve to breathe through the mouth. If you are a chronic mouth breather, it will actually change your facial features. Your midface, your cheekbones will not develop properly. It creates a long face. The bones around the eyes do not develop properly, and you will end up with downward slanting eyes. And that's because the mid-face proper development is partially due to pressure from the tongue on the roof of the mouth. If you are a mouth breather, your tongue will not rest against the roof of your mouth. And if you don't believe me, everybody, put your tongue on the roof of your mouth right now and try to breathe. You can't do it. So, what does a face look like in mouth breathers? I want you to pay attention to the pictures on the left. On the bottom left there, the cheekbones are poorly developed. The teeth tend to be more crooked than normal. The face is very narrow. If you look on the lower picture on the right, creates a smaller airway. Tired eyes, that's the downward slanting eyes, versus normal facial features, which is the illustration on the top. Mouth breathing also causes changes in the gum tissue. It dries out the gum tissue. It can turn the gums red. And like you see on the left, it can cause swelling of the gum tissue like you see on the right. And that's just because everything's so dry, there's no saliva to wash away the bacteria that are populating the area. It can cause the enamel to demineralize, which is essentially the first step of dental decay. So that's why we have teeth crowding in the upper jaw. So it's a little bit different as to why we have tooth crowding in the lower jaw. Tooth crowding in the lower jaw is caused really by one reason, and that is a small lower jaw. The dental name for it is micrognathism. Very common in Noonan syndrome. So you can see this young lady here. You may ask yourself, well, how do I know if I have a small lower jaw? Easy to tell. If you look at somebody in side profile, 3 spots should line up in a perfect line. 1, the forehead. 2, the spot right under the nose. And 3, the chin. So you can see the young lady on the left, from the forehead to the floor of the nose, the bottom of the nose, perfect straight line. But from the bottom of the nose to the chin, we have a bit of an angle. That's how we know we have a small lower jaw. After orthodontic therapy, after growth, you can see the jaw has normalized, and the forehead, the spot under the nose, and the chin are in a perfect line. So what does all this mean? Because the lower jaw is undersized, it leads to tooth crowding. All right, if it's not big enough, there's not enough room for the teeth. In infants, they will show a failure, symptoms of failure to thrive. They will have periods where they stop breathing in their sleep. That's known as sleep apnea. Inability to feed or prolonged feeding. Breathing will be very noisy. They don't sleep well, and they have a hard time gaining weight. Now, when my son Ethan was diagnosed, he essentially had all these symptoms. So based off of this is what led us to get the genetic testing. That's how we found out Ethan had Noonan syndrome. So these problems are caused because the tongue blocks the airway. So if the jaw is small, if the jaw is retruded, the tongue is retruded, and it just rests in the back of the throat. So that's how the small jaw can cause the breathing problems and the feeding problems, as well as the tooth crowding. But we do have some good news for you about the small jaw, and that is it tends to correct itself to an extent as the child grows. 99% of these are treated without the need for surgery. And by treatment, I mean orthodontic therapy. So because of the discrepancy in jaw size, because of the high palate, we'll see that the teeth don't quite fit together as they should. And again, it's the consequence of the high palate and the small lower jaw. Because of the small jaw, we'll have something called an overbite, which I think you know what that is. Now, it's normal for the front teeth on the top to overlap the bottom teeth a little bit, but an excessive overbite causes the front teeth to actually bite down on the lower gums. We also call this a deep bite. So that's one common bad bite or malocclusion that we see in Noonan syndrome. Now, because of the high palate, we'll see another one, and it is called a crossbite. Crossbite is where your upper teeth bite inside of your lower teeth. So I want everybody to bite your teeth together right now. And you will find out that your upper teeth fall outside of your lower teeth. In a crossbite, that is completely the opposite. So there's your normal bite. You can see that the top teeth overlap the bottom teeth. That's how things are supposed to be. But because of that high palate, we're not going to see that very often. We're going to have a crossbite. Crossbite is where the bottom teeth, not the top teeth, the bottom teeth overlap the top teeth. And here's a clinical picture of it. You can see that. And this is due to the high palate that this young man has. How are these treated? 99% with orthodontics. Jaw surgery is needed in a few select cases. And I would say that's 1 to 5%. So that's it. There's a lot more bite discrepancies that we can have in Noonan syndrome, but I know we're limited on time. So those are the two most common. So now we'll talk about some tooth development anomalies. And the most common one is just a missing tooth where certain teeth do not develop. And dentally, that's known as hypodontia. Noonan syndrome, this is most commonly seen with wisdom teeth, which is a great thing if you don't develop wisdom teeth. Upper lateral incisors. So your two front teeth are called central incisors. So just outside of your two front teeth, those are your lateral incisors. And then your lower premolars. Premolars are the teeth, as you can imagine, in front of the molars, and they're behind the canine teeth. My son Ethan did not develop a lower premolar on the lower right, but I'm going to argue that's not necessarily a bad thing. Because what have we talked about? The number one issue with teeth in Noonan syndrome is they're crowded. So if you're missing, say, a lower premolar, that automatically is going to alleviate some of the crowding. That leads to less work for the orthodontist, less time in braces, so you have a happier patient. So all in all, it's not a bad thing. If it's a front tooth, the lateral incisor, yeah, maybe it is a bad thing, but that can be addressed with dental implants to replace those teeth. The second tooth anomaly, most common tooth anomaly that we see in Noonan syndrome are retained baby teeth. So we have baby teeth, but they just don't want to come out. And that's also not terribly uncommon in the general population. So if this happens, when these teeth are retained, the roots are almost 100% resorbed, and these teeth can be removed very easily to allow the permanent teeth to come in underneath. The third thing we see with Noonan syndrome is some of the permanent teeth just don't want to come down. Specifically, the upper canine tooth. We call this an impacted tooth. The most common impacted tooth in the mouth are wisdom teeth. The second most common is an upper canine tooth. And these upper canine teeth are what we usually see with Noonan syndrome. This is treated by going up into the area, attaching a chain to the tooth, tying the chain around the orthodontic wire, and then traction is applied to the tooth, and the tooth comes down into place. Again, this is no big deal. It just takes a little bit of work and a little bit of time. Next, we're going to talk about the eruption of the baby teeth. The first baby teeth to erupt are usually the lower central incisors. Again, those are your two front teeth at about 6 months of age. The last teeth to erupt are the upper second molars, and that's around age 2. So let's skip this slide. Let's go to the next one. This is a popular slide at the Noonan syndrome conferences. People like to take a picture of this slide so they know when these primary teeth, these baby teeth, are supposed to erupt, when these baby teeth are supposed to be lost, and then when the adult teeth are supposed to come in. So how does this impact those with Noonan syndrome? Take those numbers and extend them by 3 months, by 6 months, by 9 months, even up to a year. So all these eruption times, all the times that the baby teeth are lost, are usually delayed in those with Noonan syndrome. It will happen. The teeth will be lost. The adult teeth will erupt, but it just takes a little bit longer. So it takes a little bit longer for the tooth fairy to show up. She'll show up. It just takes her a little bit of time. So really none of this is that big of a deal. Everything is fixable. But now, unfortunately, we need to talk about one jaw tumor that is of significance in those with Noonan syndrome. And it is called a central giant cell granuloma. It is a tumor of the jaw. Fortunately, it is not cancer. The bad thing, I think, is a small proportion of them can actually be destructive to the jaw. Now, I'm sure nobody here went to dental school, but I think you can look at this dental x-ray and you can see that, yeah, that dark area is probably not supposed to be there. And you are correct, it is not. That is what a central giant cell granuloma looks like on a dental x-ray. That's how most of these central giant cell granulomas are found. Just a routine dental x-ray. Every now and again, the jaw will expand a little bit. So you go to the dentist and you figure out, hey, what's going on here? They take an x-ray, they see that, and they send it either to a periodontist or an oral surgeon for a biopsy. Fortunately, most of them are asymptomatic. They grow very slowly. Unfortunately, a small percentage of them are aggressive. They cause pain, and they will expand the jaw. The most common area that we see them, the anterior mandible, the anterior lower jaw, from the canine tooth back to the premolar teeth. And again, the premolar teeth are the teeth that are in front of your molars. I have never seen one outside of this area. I've had to deal with a few and biopsy a few, probably 20, 25, and they're all in this location. Tends to occur in younger adults under the age of 30. There's a 2-time female predilection to males. The asymptomatic slow growing type, is surgically removed, and it is extremely rare that it comes back. That is not the same with the aggressive type. It tends to recur. With the aggressive type, you can have multiple central giant cell granulomas. You can have 2, you can have 3. I've seen them with up to 30 small ones throughout the lower jaw. And that opens up a whole nother can of worms. Obviously, you can't do surgery to remove all that, but there's a drug that is used now that works great to help with situations when surgery is not an option. The aggressive type will displace the teeth, tends to spread the teeth apart, tends to push the teeth up, and it tends to make the teeth very loose. So again, 60%, most of these occur before age 30. 70% arise in the lower jaw. I have never seen one in the upper jaw in my 18 years of private practice. So if you just have one, treatment of choice is surgical removal. And then how we do that, we make an incision in the gum tissue, and we use these little instruments called spoon curettes, which, as you can imagine, they look like spoons. And we just scoop out the tumor. We clean it out. If it has destroyed quite a bit of bone, we'll do a bone graft, stitch the gums back up. Life's good. It never comes back. But what if surgery is not an option? What if you have multiple central giant cell granulomas that spread all throughout the jaw? Well, there's a drug called Xgeva that is now used. It's a relatively new treatment. It's been used in university settings for about the last 5 years. It's a different name of an osteoporosis drug called Prolia. So they just market it differently. So the Xgeva treatment for those with multiple central giant cell lesions, it's a shot that you take under the skin once a month. The Xgeva it came out to prevent really serious bone problems in people with multiple myeloma, which is a type of cancer, or people who have metastatic cancer that is spread to the bones. They figured out about 5 years ago it cures those central giant cell granulomas. It's given once a month for the central giant cell granulomas for at least 1 year, many times longer than 1 year. You're not going to go to your local dentist. You're not going to go to your local oral surgeon and have this done. This is done almost solely in a university setting, a university hospital. Around here, I'm in Lexington, Kentucky. If you need this treatment done, you go to Cincinnati Children's Hospital. So I know our time is limited, so let's conclude here. Oral health care for the Noonan syndrome patients should begin early in life in order to prevent the problems from becoming irreversible and unfixable. As we talked about the crowded teeth at the beginning and the high palate, and the bites that maybe aren't ideal, proactive orthodontic treatment should be administered as early as possible to address the palate, the tooth crowding, and the bite issues. I recommend your first orthodontic visit be at age 7. I recommend your first dental visit be when the first teeth erupt. And those with Noonan syndrome and the general public, regular dental visits are a must. You don't skip the dentist just because it doesn't hurt. Going to the dentist is just like a maintenance, just like you get your oil changed in your car every 5,000 miles, every 5,000 miles. To maintenance. So again, anybody is more than welcome to contact me at any time over the years, I've probably had 60 to 70 people either email me or call me on my cell phone or send me a text. I always get back to you within 24 hours. If you would like the little cheat sheet that I've made for dentists, I'm more than happy to email that to you as well. So with all that said, I would love to take any questions that you may have.
Yeah, and Dr. Browning, I'll just kick us off because there's already a couple questions that have been posted in the chat.
Okay.
So Morgan asked, how often would you recommend Pano to monitor for CGCG?
If there's no history of it, once every 2 years. If there's a history of it, or if there is maybe what may look a little suspicious on a dental x-ray, then we do that once a year. With a history of a central giant cell granuloma, once every 6 months. And usually those who have had a central giant cell granuloma, or who maybe have a suspicious area on the panoramic x-ray, the Panorex, we will take a CT scan. So a lot of the periodontists and the oral surgeons, we have CT scans in our office, and it's specific. It's not a medical CT scan, it's a dental CT scan. So it shows us all the jaws and the sinuses and the nasal cavity in 3 dimensions. So it's a long-winded answer to say if there's no issues, every 2 years.
Question from Stacy. What about demineralization? Any way to help restore the teeth?
You can speak with your dentist about this. There are prescription fluoride toothpaste that work well. There are some prescription products that we call MI paste, which is a calcium-based gel that can be applied to the teeth. Most teeth in the anterior, in the front of the mouth, that are demineralized, fortunately, do not progress to dental decay. And usually the only reason we see that is because of the mouth breathing. The mouth breathing really dries the mouth out. Saliva is what we need to wash the plaque away. And if you're a mouth breather, obviously the front of your mouth, your whole mouth is extremely dry. So if mouth breathing is not an issue, virtually a 100% chance that will not progress into actual dental decay.
Question from Brian. You mentioned a delay in the loss of baby teeth and eruption of adult teeth, but could you comment on any delay in the eruption of baby teeth earlier in life?
The delay, that's also delayed. So baby teeth, remember the first teeth, baby teeth to erupt should be the lower central incisors. Again, those are your 2 front teeth on the bottom. They usually erupt at age 6. My son's didn't erupt till he was, I think, 13 months old. It's very common, very common. They'll come in. They'll come in. It just takes a little bit longer. Is it a big deal? Not so much. But everything with baby teeth eruption, baby teeth loss, adult teeth eruption, virtually everything is going to be delayed, and probably at least 75 to 80% of those with Noonan syndrome.
Question from Nikki. My son seems to have a lot of saliva. Is this normal for Noonan syndrome? He wakes up with a wet pillow, and also it seems to affect his speech at times.
That's not normal. I think that's unrelated to Noonan syndrome, but excess saliva is better than having not enough saliva. The more saliva you have, the research shows, the less prone you are to having dental decay. Because what did we just talk about with the mouth breathers? They don't have saliva. They don't have the means to wash away the plaque and the bacteria on the teeth. So all the research has shown that the more active that the salivary glands are, the more saliva that is produced, actually the less dental decay that you will have. Is that related to Noonan syndrome? I do not think it is, but it's really not a bad thing.
There was a follow-up question about the panos, and so for children, when would you start taking the panos to monitor the CGCG?
Probably around age 6 or 7. It's rare they form uh, that early in life. I've never seen one form. I've seen one at the age of 9 that forms. So I'd say around age 6. And again, I would like you to have your first orthodontic visit at age 7. When you go to the orthodontist, age 7, you're going to get a pano then and there. But it certainly wouldn't hurt to have at least one a year before that, before you see the orthodontist. Don't see any reason to have it any sooner than that.
Question from Mary. My son is 2.5 and seems to have enamel hypoplasia. He seems to have multiple cavities. Think there's been 6 so far, and his mouth really seems to be struggling. Feels like we're just pouring money into the sealant every 3 months. Should we be seeing a different dentist?
Um, without without any personal information about the dentist that you are seeing, um, here's what I tell people. You have to be, and this is good advice for physicians, for dentists, for any healthcare professional that you're seeing. If you're not comfortable with them, if maybe there is a lack of trust with them, there's nothing wrong with getting a second opinion, because it's your body, it's your mouth, it's your child's body, it's your child's mouth. So just based on the fact that you're asking that question, I certainly think it would not be a bad idea to go get a second opinion.
From Shauna, my 24-year-old son has very yellow teeth and tried whitening from the dentist with the tray, but his teeth turned spotty, so we were scared to continue. Is that due to low enamel? Um, the spottiness did go away, but should we continue?
With the whitening, how can she follow up with how long the whitening was done?
Yeah, and Shauna, if you want to just come off mute too, that's possible. But it sounds like it was just one treatment.
Yes, just one.
Just one tray, just one bleaching
Yes.
one bleaching
Yep.
episode. No,
Yes.
stick with it. Stick with it. There's not enough time for the peroxide to do its work. So the very good chance with they're different whitening products, professional whitening products. Some are 2 weeks long, some are up to 4 months long. So whatever it is, I would finish it out. You're certainly not doing any damage to the tooth.
Okay.
Yeah, so if I certainly would not be concerned with it, and just roll with it.
And the spottiness would not be permanent?
No, it would not.
Okay, great. Thank you.
You're welcome.
This is a question from Catherine. What would you say for a 9-year-old boy with severe HOCM and a horrendous mouthful of rotten teeth, not from lack of dental hygiene? All of the dentists and residents at Boston Children's only want to rip every tooth out of his head, saying, "Oh well, the adult teeth will eventually come in." I'm desperate to find him a dentist who understands all that is going on in his mouth. His dental issues have impacted his life greatly. Because of his severe HOCM, no one outside of Boston Children's will even treat him.
Well, I hate to say this, but I don't know what HOCN is. If you could pass that information along to me.
It's hypertrophic obstructive cardiomyopathy.
Okay. So you said nobody wants to explain what the issue is again?
So he's just from infancy, from childhood, ever since he got his teeth. For some reason, they decayed early.
Okay.
Maybe because of all the medicines he's been on, because he's medically complex. But
Yep.
he had 6 baby teeth taken out at age 3.
Okay.
And those 6 top teeth have not come in yet. I understand there's a delay. He's 9
Mhm.
now, but the teeth still haven't come in. They say that they are up there when they x-ray, but the rest of his baby teeth that are left and the couple of bottom teeth that he's lost on his own and the big ones that are coming in are decaying, probably because of all the other decay in his mouth. So everybody just wants to rip the teeth out, like all the teeth out of his head. And he already had, having 6 teeth ripped out at 3, he had speech impairments. I don't have to tell you everything that he went
Right.
through, feeding difficulties, and he's overcome all of that. And I'm trying to do whatever I can to save what's left of his teeth, but because of his other medical complexities, nobody outside of Boston Children's wants to treat him.
Right. So without seeing an X-ray, I probably wouldn't be able to give you a satisfactory answer. But the issue with multiple areas of dental decay, there is a risk of an abscess developing around one of those teeth. Because if you think about it, dental decay is an infection. It is caused by Streptococcus bacteria that finds some sugar on the teeth. It eats the sugar and then it excretes an acid, right? So people don't think of a cavity or dental decay as an infection, but technically it is. Multiple areas of decay, people are at risk for developing an abscess. This abscess can be very small. This abscess could be no big deal. This abscess can be a monster and put you in the hospital. And I had one in my practice last week. We had to send her straight to the emergency room for emergency surgery because of a significantly decayed tooth. The medical center that you're at is top notch. And yeah, because of the hypertrophic cardiomyopathy, probably should be treated in a hospital setting. You're not going to find a pediatric dentist on the corner that would be willing to treat that. So I can't really answer your question, but those are some things to think about.
Thank you.
You're welcome.
Question from Nicole. Are teeth extractions needed often for those with Noonan syndrome? My daughter's 2 top front adult teeth were ready to come in, and the baby teeth had lost the blood flow and were changing color, so we opted to have them pulled.
The baby teeth, they do lose their blood supply because the roots resorb. The roots resorb because you've got 2 adult teeth that are putting pressure on the roots. So as the roots resorb, the teeth lose their blood supply. They turn yellow. And so it's not any type of abnormal pathology that caused the teeth to turn yellow. That's just the normal process. of losing baby teeth. So yeah, there's certainly nothing wrong with pulling those teeth. You could pull them, you could leave them there. Really, there's no right or wrong. But the losing of the blood supply is 100% perfectly normal.
Mary, go ahead and come off mute and ask your question.
Yeah. So I was the one who has my son has 6+ cavities. It just feels like his mouth is just riddled. He doesn't have the similar cardiomyopathy heart condition. He has a heart condition, the heart condition of Noonan syndrome. So I'm just trying to figure out.
What is it? Is it pulmonary valve
Um,
stenosis?
Yes, pulmonary valve
Okay.
stenosis.
Okay.
Um, and his cardiologist has not said that he needs to have anything before he gets a dental visit, which is good. I just don't know if he needs to be seen by a dentist that is in a hospital setting because he has such intense so many cavities. I just don't know if a normal pediatric dentist is the best place because it feels like we are the patient that is there all the time versus the average kid. Like,
Right.
is a different practice better
No,
for
so
kids with
some
cavities?
pediatric dentists, the ones that actually I have a group in my dental office building, and they have one, and a lot of pediatric practices are like this. They will have one person that has hospital privileges to do treatments in the hospital or in some type of a surgery center. So I think what I would do, and if you're in a small town, that's, maybe not as likely. I
Fair
think
enough.
your best bet would be to call around to the pediatric dentists and say, hey, do any of you do hospital dentistry? And if they do, you make an appointment with them in their office and you chat with them about what is going on, and they will make a decision as what needs to be done from there.
Okay. We don't live near U of M, but if there's like, you mentioned university dentistry, I assume this is not that level by any means, but
Correct.
like, I'm just willing to make big moves because it just feels like his poor teeth, which it seems like that's just like a common thing of Noonan syndrome, but
Yep.
it's,
U of M, are you talking about Michigan?
yeah, I mean, it's 2
Okay.
hours from us. So
2 hours. Okay. Ann Arbor's 2 hours. They have another option. Detroit Mercy and University of Michigan. Michigan's got a very good dental school, and they have a very good pediatric dentistry residency.
Mm.
And in that residency, all of their residents have to learn hospital dentistry. So that would be another option for you. I know it
Yeah.
would be inconvenient to drive 2 hours, but there are pediatric dentists. Long story short, there are pediatric dentists that do work in a hospital setting. You just have to seek them out.
Okay. Yep. Yep. I appreciate that. Thank you.
Yep, you're welcome.
Question from Leo. Is tooth misalignment something that's associated with Noonan syndrome?
Yes, it is. I assume you missed the first part of the lecture. We have tooth misalignment in the upper jaw because of palate, the high palate or a narrow palate. Again, the palate is the roof of the mouth. We have crowded teeth or the malocclusions, the bad bites with the bottom jaw because in Noonan syndrome, the bottom jaw tends to be a little bit smaller and there's just not enough room for the teeth to erupt. in a straight fashion. But the number one issue that is seen in those with Noonan syndrome far and away is crowded teeth.
I think there was one additional question that came through in the chat from Morgan. Can you discuss higher cavity risk with frequent snacking in kids with Noonan syndrome and how to combat that with frequent meals?
Now that would be no different than anyone in the general public. So we just have to think again, what is the pathology of dental decay? Dental decay will not happen without the presence of sugar on the teeth. Okay, so bacteria, Streptococcus bacteria, that is normally found in the mouth. They eat sugar. That's their food of choice. They eat sugar and they excrete an acid. That acid is what causes the dental decay or the cavities. So whatever the snacking is, whatever the frequent feeding is, you have to minimize you have to look at what you're eating. Turn the box around or the carton around and see what the sugar content is. And just realize that if that sugar sits on the teeth long enough, you're going to get decay. So you have to really optimize oral hygiene in situations like this. Maybe you have to brush more than twice a day. Maybe you have to brush 3 times a day. There's no research that shows there's a correlation in higher cavity rate in those with Noonan syndrome versus the general public. Although I certainly have seen it, and I do think, and this has not been studied, this is just my theory, that many kids with Noonan syndrome just genetically have thinner enamel. And a lot of times it's not necessarily the parent's fault for not helping the child brush his or her teeth, or it's not the child's fault for not brushing properly. I think sometimes we're just, those with Noonan syndrome are just born with thinner enamel. But again, long-winded answer to say you got to keep that sugar off the teeth.
Yeah, I think we'll make this the last question here before we wrap up. From Shauna, my 24-year-old son had a ameloblastic fibroma of the
Yep.
mandible
Mhm.
removed when he was 10 years old,
Yep.
and the report said that it could reoccur, but it hasn't. Do I need to be concerned about the follow-up?
Yes. Panoramic X-ray. Um, um, when was it removed? How long ago was it removed?
14 years
14
ago.
years ago. And it has not recurred in 14 years.
Well, not that we know of. I mean, he hasn't had a panoramic. I mean, no one really followed up since that time with a panoramic. I mean, he goes to his 6-month dental checkups, but
Okay.
would that be something that would be seen there?
On a panoramic X-ray, yes, those ameloblastomas don't look very much differently than the central giant cell granulomas. They usually appear in the posterior mandible, posterior the lower jaw around the wisdom tooth area. I'm not sure where yours was, but it is very apparent that if it's there, any dentist worth his weight in his education will be able to see that pathology and will refer to the proper specialist. Because it was 14 years ago, I certainly, I would make the dentist aware of it. If they don't know, make sure it's in the medical history, and I would, if they don't want to take a panoramic X-ray every 2 years, I personally would demand it.
Okay. So do they have the capability of doing a panoramic at the regular dentist? Or
Absolutely.
is that
Yeah, every
Okay,
dentist,
okay.
I do not know a dentist who does not have a panoramic X-ray machine.
Okay, but they generally don't do them necessarily on your 6 months check.
The American Dental Association recommends one every 2 years.
Great, great. Okay, thank you.
You're welcome.
So I'm going to go ahead and stop the recording. There were a couple questions about this being available.